Good morning and welcome. My name is Adrian Park at Anne Arundel Health System in beautiful Annapolis, Maryland, and it's my pleasure this morning on behalf of myself and my co-directors, Dr. Phil Schauer and Steve Wexner, to welcome you all to this month's broadcast of the Innovations in Surgery program. I want to just do a very brief roll call. If you don't hear your institution's name mentioned, please let us know. As we say for every broadcast, the real benefit from this program is when we have good interaction from all the sites, or as many sites as we can, attending around the world. So this morning we have Carolinas Medical Center, Cleveland Clinic Maine, Cleveland Clinic Weston, Dalhousie University in Halifax, Duke University, Geisinger Clinic, the Imperial College in London, IRCAD in Strasbourg, the University of Strasbourg in France, Johns Hopkins University, Lankenau Hospital System, the Massachusetts General Hospital, McGill University, Medical College of Wisconsin, Mount Sinai Medical Center, the Ohio State University, Centara Lee Hospital, Sher Zadek Medical Center in Israel, the University of Kentucky, Virginia Commonwealth University, and the Walter Reed National Military Medical Center in Bethesda. So we have a good group this morning. And I want, as always, to thank our sponsors. You saw them listed at the beginning of the program. It really is a great pleasure to be able to introduce our speakers this morning. Professor Lord Eridarzi needs no introduction to this audience. His colleague, Mr. Daniel Leff, is the official clinical lead for the Neurogenic and Perception Laboratory at the Hamlin Center for Robotic Surgery at Imperial College in London. And Lord Darzi and Mr. Leff are going to speak to us this morning on neuroergonomics and surgical robotics. A little bit of a departure in some regards from the more clinically focused topics we've had, but I think you're going to find this fascinating material germane to all of us in terms of not just surgical education and training, but maintaining our own skills going forward. You'll see a number at the bottom of your screens, and again, I welcome you and encourage you to call in with questions or your comments you might have through the course of the program. Era, I see you there this morning. Welcome. Daniel, we'll hand over to you at this point.
Thank you very much, Dr. Park. Lovely to see you, and thank you very much for inviting us to contribute to this, and I think the whole team looks forward to really being part of this in the future. So a big thank you. Yes, it is an interesting subject. It really started by me trying to prove to my many physician or internist colleagues that surgeons have a superior brain, and I had to find a way of objectively measuring that, and I found the brain who is beside me, and that's Daniel Leff, who's done a superb PhD in this area. Daniel is a senior resident coming to an end of his program, and he will be joining us as an attending next year. And I'm really going to leave it to him to give you a brief of the work we've been doing here, and then maybe after we can have some further discussion. We have a number of clinical fellows here, and also joining us is Sir Tom Hughes-Hallett, who is the chairman of our Institute of Global Health Innovation, and he has an interest in what we're doing on certainly being part of this this teleconference and tele-education program. So thank you again, and hand over to Daniel.
So thank you very much, Professor Darzi and Professor Park. My intention this morning really is to try to give you an overview of the program. Really, we've made a fair amount of progress in this field, and it's a bit difficult to give you a complete overview. We're really trying to give you some highlights and to really explain some of the concepts and theory behind the program. So we would start by introducing the concept of neuroergonomics in terms of what is neuroergonomics. And it was really Parasu Raman in 2003 who coined the term. Essentially is a synergy between neuroscience and ergonomics to essentially better understand our performance. And really what we're trying to do within the Neuroergonomic Lab at Imperial is to try to bring neuroergonomics into surgery, to see how can we use this new science to better understand surgical performance and training in surgery, with the intention of leading towards safer working conditions. Really, this is something new for us as a surgical community, and it really enables us to look at very interesting areas of our performance, such as fatigue, what happens when we're fatigued, can we detect hypovigilance in surgeons, can we assess learning curves, but from the point of view of integration of those skills at brain level, looking at errors, and looking at operative decision making, and I'll be able to give you some of an insight into a few of those areas this morning. So essentially, just to give a bit more background here, the work that we were doing within Imperial College, and indeed many of you that are logging in across the world this morning, have done to improve objective assessment of technical skills. There's been a tremendous advance in this field. The advantage was that we would now be able to get objective data about technical skills that we could use to either understand brain behaviour or indeed potentially correlate with brain behaviour. In addition, work before I arrived in the department was starting to look at eye tracking technologies and perception in surgery, and really eye behaviour is a window onto the brain, so it made logical sense to start thinking about evaluating brain function in surgeons. The tools and technologies that we had were showing us some very interesting findings that we couldn't really understand at this point. An example would be on the left of the screen as you look at it there, overlap in performance using objective measures between different grades of surgeon, vast variation in performance amongst surgeons with similar background. And we started to think about this from our own objective experience, certainly the more senior trainers, that as the right of the plot as you see there, that undoubtedly people acquire skills at different rates. And we heard yesterday in our own surgical symposium, Professor Gramchov talk about 8% of trainees perhaps never achieve a stable task performance. And really we wanted to try to understand this. We believe that maybe some of the key to understanding this is at brain level. Another area of great interest is in selection, and perhaps we'll hear later from some of you about how you select your trainees. There's a lot of great interest in correlating technical performance with innate abilities, but by and large, there is a very poor correlation with manual dexterity, pure manual dexterity, and so on with technical surgical performance, with perhaps some isolated exceptions. So there's got to be more to it. So we became very interested in looking here at the surgical brain. It's a very complex organ, very much the organ of the 21st century, to try and understand in a lot more detail how this is behaving. To give you a much clearer idea going forward, from this point forward, we are now talking about human brain function, not anatomy. We're not looking at the anatomy of the brain, we're looking at which parts of the brain are being recruited to perform surgical tasks. We then had to determine, based on this, what were the challenges of understanding technical skills in surgery from a brain perspective. And really you can see from this illustration here that there are many challenges in terms of how do we obtain reliable neuroimaging data in people who are freely mobile, in people who are using metallic or surgical instruments in a potentially claustrophobic environment such as that of a magnet. So there were many challenges, and we realized we needed to look at this in a lot more depth with respect to what tools and technologies were out there. Very broadly, so for those of you that are perhaps not so familiar with neuroimaging technology, this can be subclassified into either direct neuroimaging modalities, those that are monitoring the electrical activity in the brain, or indirect neuroimaging modalities, those that effectively monitor the hemodynamic response. And we'll come back to that in a second. Very briefly, with respect to neuroimaging modalities per se, really it's about how can you localize in space and time brain activation. And the technologies are not equal, as you can see here. For example, MEG and EEG are very fast technologies. They'll give you millisecond temporal resolution, but spatially they're poor in terms of identifying where the activation is coming from. Functional magnetic resonance, much better at spatially identifying activation, temporally very reasonable. PET is certainly temporally not the most sensitive technology, and one that we will probably discount, and we'll explain more why in just a second. So with respect to EEG, we were looking at, was anyone using EEG? Well, actually in 2011, only recently, there's been a study looking at laparoscopic skills and coherence between two areas of the brain, a brain that's involved in verbal reasoning and area of the brain that's involved in motor planning. And what's very interesting, if you look at the plot underneath, is that technical skills were improving, whether subjects were learning in an implicit fashion, that is in a fashion where the explicit sequence of learning was suppressed from them, or in an explicit fashion where it was very explicit what was to be learned. So they learned regardless, essentially, of the mode of training. But what you notice about their brain behavior was it was very different. Certainly the coherence, the communication, which we'll come back to hopefully later this morning, was very different if you learnt in an implicit fashion as opposed to an explicit fashion. So I think this is the first illustration, or one of the first illustrations, that you cannot glean this information out based just on the performance data. You need something more to tell you about the way in which the brain is behaving. You would not glean this information just by looking at their hands or their performance. But this technology was a technology that we discounted at this point, because being able to identify spatially where the activation was coming in the brain was very difficult at the time we were exploring it. So we've moved away from that technology. Magnetoencephalography, looking at the magnetic field potentials from the brain. The magnetic field potentials are quite weak. It needs very powerful technologies to pick up the magnetic fields. You could see that you probably couldn't do a tremendous amount of surgery sitting in that environment. And so you won't be surprised to hear many people pursuing that technology. With respect to positron emission tomography, another very elaborate technology, a very nice technology, but I would have to ask myself and my colleagues to be injected with radioisotopes, and it's a very slow technology. So really, I felt that our cohort would go down dramatically by the use of this particular technology, and so we've moved away from this as well. Functional magnetic resonance imaging is probably the cognitive neuroscience gold standard, and the top left plot summarizes how it works. But essentially, you're looking in your T2 weighted signals for changes in the magnetic properties related to hemodynamics in the brain. So you're monitoring a secondary event. You're not monitoring activation, you're monitoring the hemodynamic consequence of activation, if you will. And in terms of, is anyone using this technology in surgery? Probably one of the first papers was by Carl Wanzel, looking at mental rotation in the magnet, but not really looking at surgery as such. Barami et al. More recently using it, but again, you can see from the bottom plots there, I would hope, that we don't learn surgery like this. We're not lying down as we learn it, we're not lying down as we perform it. It's a constrained environment. It won't translate, in my view, to the operating theatre environment, and whilst it's certainly giving you great depth, it will give you subcortical information, it's probably not a technology that right now we can translate to the OR. So this led us to functional near-infrared spectroscopy, which very briefly works by shining light onto the scalp and detecting it back at various fixed detection points. And essentially, you interpret the drop in light levels as a change in the hemodynamics. So in many ways, it is functioning in a similar way to functional magnetic resonance, but it blends the benefits of EEG, if you will, in that it's a scalp monitoring device. To give you a little bit more information on exactly what we mean by hemodynamics, the hemodynamic response is tightly coupled to neuronal activation. So if you fire off your neurons in your brain, you will get a local hemodynamic change, which is an increase in the oxygenation, increase in the blood flow, and that is vastly, the increase in the oxygen is vastly uncoupled to the extraction of oxygen. So you get much more oxygen to the brain area that you are using than you need. You don't necessarily extract as much oxygen, and you wash out the deoxygenated hemoglobin, and that's what we look for in near-infrared spectroscopy. So to give you a very brief video of essentially what the technology looks like. Essentially, the working end is a series of light emitters, light detectors, as you see here. These will fit into a thermoplastic device, which is shown here in a fixed array, in this case 3x3 array of near-infrared emitters. You can see that here I'm trying to demonstrate that the light is, we can emit that through the tissues, and we can still pick up the near-infrared and red light as it emerges from the tissue. You'll see in a second how this sits on the trainee's cortex, how it's engaged on the scalp surface, and how it's relatively comfortable to wear in a real laparoscopic environment. We're able to, with the technology that we have, build up maps of brain behavior and overlay those onto anatomical maps so we get a better understanding of the underlying anatomy, of which areas in the cortex are recruited. To move on and show you that essentially we don't have an anatomical map as such with near infrared. We have to use a standard framework, which you're seeing down below, based on EEG data. And the process involved in collecting data is quite time consuming if you're going to do this right. One really needs to take the time to position appropriately, to know where you're related in terms of, this is a system known as the International 1020 system, so that you can reliably interpret the information from the cortical surface with respect to the underlying anatomy. There are colleagues of ours that have developed programs in order to do this. So all you need to pay attention here is the yellow dot, which is the 1020 head surface position, and you can see that the cortical projection point, which is the red dot, is slightly different from where the head surface position was recorded. This slide is probably one of the most crucial slides for you to understand going forward in terms of the data that we'll show you. Essentially, if you imagine a scenario where you're performing a motor task and you're positioned with your near-infrared spectroscopy over the motor cortex, during a period of time of stimulation, the typical response you expect to see is a rise or an elevation in the oxygenated hemoglobin, that's the red line, an increase in the total hemoglobin, unsurprisingly, the green line, and a drop in the deoxygenated hemoglobin, which gets washed out of the activated area. So that pattern that you're seeing at the top of your screen is the pattern we go hunting for in the data. And that's really the long and short of it. That's what we're looking for to tell us whether an area has become recruited or not. In terms of just a brief history with the near-infrared spectroscopy, to put this in some kind of context, if you look back at where near-infrared has been used, really they were looking at very basic motor tasks, even up to not so long as 2006-07. Surgery is, I think, by far the most complex task, although let's say something such as open surgical knot tying to yourselves as surgeons, you view this perhaps as a very straightforward, very basic task. In NIRS terms, this is highly complicated in terms of brain imaging, where we are at the moment. So I think Dr. Parr may want to pause at this point just to see if there's any particular questions and to make sure we haven't lost anyone at that moment.
Thank you very much, Daniel. Let's go to Cleveland Clinic, Maine for a sec. Dr. Shower and colleagues, so are you gonna start putting your prospective residents or fellows into a scanner, or what kind of tools or technologies are you interested in looking at in terms of selecting the best and the brightest for your program?
Yeah, Adrian, this has been a fascinating presentation. It reminds me of just 4 weeks ago when we were watching these world super athletes performing in London, and much of these world records, it seems, have been accomplished by scientific study of movements, and whether it's sprinting or other performance of sport. So I think just now, surgery really is it's a skill, it's a performance, and we're just now getting into the science of learning how to enhance performance in the operating room. And I think the speakers have shown us a variety of fascinating brain imaging technologies that seem to be kind of in their infancy. And I must admit, here in Cleveland, we're basically doing fundamentals. We have been applying simulation technology, proven skill training concepts such as fundamentals of laparoscopic surgery, the FLS program, and some of the real basic simulators. And they seem to work, and they're fairly cost effective, but we look forward to seeing some of this advanced technology be applied in the near future.
Thanks, Phil. I'd like to go actually for a comment to our colleagues at Walter Reed, the National Military Medical Center. Not sure who's there this morning, but I'd like to put out a question. You have a unique combination of trainees who are being trained in medicine and surgery, but also trained in other technical military skills. I'm not sure who we have there this morning in terms of leaders, but can you speak to, are there any differences in the skills and the technical skills learned for some aspects of your military training versus what we do in surgery? Are we lagging way behind? Are there more precise means of accessing acquisition of skills in other than surgical training? Do we have Dr. Lin or?
Hey, Dr. Park, this is Scott Rarick here. I don't really think we have any specific high-tech technologies we're seeing in the VTC this morning. We certainly, Dr. Ritter, over through UShoes, has pushed advances in our curriculum, and is based on FLS, and we have the standard technologies that we apply for training a residents. So this is a very interesting area. Certainly we see some of these technologies applied when they try to go back, I will say, in treating our TBI patients who come through the war. And so I have been exposed to some of this technology, and I think it's very interesting to understand about how certain areas of the brain can adapt or be retrained. So from that standpoint, I think it's very interesting.
Great, thank you. Helpful comments. Daniel, let me return back to you.
Yeah, so we'll pick it up from there. So now, just in order to understand the hypothesis, let's say, that we were generating, and some of the learning related work that we've done, it's useful just to recap very basically the overview of the literature in terms of what evidence is there for any of this. So with respect to cortical imaging techniques, really, I think we've got enough on the cortical surface to keep us busy. I mean, there's the visual cortex. All of these things are going to have a role in surgery. You know, parietal lobe for spatial function, M1, the motor areas, which behave differently depending upon the stage of performance, which I'll show you some data for. And now you're seeing there highlighted in a second the frontal lobes, an area where we've spent a lot of time looking, particularly with respect to the prefrontal cortex and supplementary motor areas. So with respect to some of the evidence for this, evidence based for the learning-related change. The important concept here is that of neuroplasticity, which one of our colleagues just really alluded to, that essentially the brain is not hardwired. It can adapt. Your best example of that is probably in disease. We all know, we've all seen patients who are slowly recovering from CVAs, and if you look at the functional data in those patients, you clearly see that the brain is adapting to cope with the insult. The same is true of technical skills training. The brain will modify itself. It will modify the synaptic connections in response to training, and I hopefully try to convince you of some empirical evidence in surgeons for this very soon. But essentially, Donald Hebbian learning goes that essentially if a cell is near another cell, cell A is near cell B, and it is so close that it will have an influence over it, the longitudinal change is an increased efficiency of cell A's firing on cell B, essentially. That's the fundamental crux of neuroplasticity. What I started to see as I was reading more in the literature was that there are some very clear and very broad unifying themes here. The prefrontal cortex really is involved in novel performance. This is an area right at the front of the brain. We know that it's involved in attention to action. The ventrolateral prefrontal cortex is involved in learning how to arrange your hands in space and time, important for surgery. Cohen and Carter showed that the prefrontal cortex and the anterior cingulate cortex are important in error detection. This is going to be something that we all do as surgeons, hopefully staying perceptive to our errors, and we'll show you some data on that hopefully later. And really, Peterson described this scaffold theory, the theory that the prefrontal cortex is there. It's a scaffold. It supports your novel demands, and then the scaffold falls away when you no longer need it, when your performance is refined. There's this concept that of redistribution, reorganization. A very good example is that the work done by Avni Karni, looking at simple motor tasks, simple motor sequence learning. If you train a sequence over a number of weeks, you see an expansion in the representation of that trained sequence in the motor cortex. This we found to be very interesting. And essentially, so redistribution goes that the areas, as you can see from the illustration, the areas involved pre-training are the same post-training. It's just that the amount of activation at the end in those regions has changed. Whereas a true reorganization of brain behavior is the areas that are involved at the end of practice or the end of training have changed. So you have different areas at the end of training to those at the beginning. And really the theory there is that there's been a cognitive shift in processing. This was we had to go outside of surgery because there was not a tremendous amount done to look at the effects of long-term training, looking at expert and novice behavior. A very good illustration of this is in musicians. And this paper by Timo Kriegs, essentially, you can see at the top, the areas of activation in the novice labeled N are very similar to the areas recruited in the expert for a piano sequence labeled E. The difference being is the extent of the magnitude of those activations is different. So not experts seem to be using smaller areas of activation, more refined networks perhaps, to achieve the same if not better performance. This we found very interesting and felt we could. And possibly most interesting of all is this concept of performance-related brain activation. This theory that those individuals who perhaps perform the best, the most brightest, or the most gifted, their brains behave differently to those who struggle. And a good example of this type of data is from the work that Tracy did on knot tying, not surgical knot tying, or sailing knot tying, and essentially found that correlation in the frontal areas, the areas that we know are associated with early learning, they persistently fired in those subjects who really struggled to learn. They either didn't learn or they had showed weak learning. They persistently fired those areas that are associated with early learning. Whereas those associated with strong learning, there was very quick shift away from the prefrontal areas. So to develop a hypothesis, myself and Professor Darzi, with respect to what we might find in surgeons, that when you're a novice, you get a broad area of activation, perhaps in these early learning areas, the prefrontal cortex, a very haphazard arrangement of networks. And as you become a master, you're refining the networks, you're refining your brain networks, and you're using, you don't waste energy, essentially. And we know that with respect to the hand, but we've never seen it with respect to the brain before. Just to give you some empirical evidence to support this, really in the open surgical arena, we thought to start simply rather than moving straight to minimal access surgery. So essentially, we looked at open surgical knot tying. And you can see that whilst this is something that we all do routinely as surgeons, if we can cast our minds back to when we were novices, and if we view it as you can see in the top left, suddenly this becomes quite a complex task again. If you deconstruct it down into its basics, it becomes quite a difficult task. So we trained, the study that you're about to see was on over 80 subjects. We trained up novices with a brief period of training so that they could perform the task. And we executed a block design, as you can see, the bottom of the screen there, with periods of rest and task to increase the signal to noise ratio. Array over the prefrontal cortex as illustrated here. This is a schematic of where the channels are essentially the grey boxes. You can see channels 1 to 12 on the right side, and channels 13 to 24. These are areas of measuring of the underlying cortex on the left side, with the Imperial College Surgical Assessment device used to monitor performance objectively. In the spirit of sort of a video or a picture speaks 1,000 words, if we just show you a typical novice procedure here, so performing an open surgical knot tying, you can see, as you all know, that the path length is particularly long. There's breaks in the flow of the procedure. Remember that this subject hasn't really been learning this task for a very long time, whereas an expert surgeon, using much shorter path lengths, essentially an overall slicker performance. What you'll see here is in the brain activations overlaid, now hopefully played at the same speed. At the top, the novice brain; at the bottom, the expert brain. Hopefully, you should see that there is a increase in, this is the cortical change in oxygenated hemoglobin in the novice. And those are strikingly different. To actually break that down, just in case you may think, well, actually this is a time-based thing. Actually, at each subset through the task, there are differences in the magnitude of the activation. So this isn't necessarily a function of how fast the expert is actually, we believe, a function of the fact that the expert really does not need to use this prefrontal cortex to the same extent. They've moved on. Whether the activations are deeper, we can't tell with this technology, almost certainly the attention and concentration will be there, but it will be at it'll be a different place in the cortex. We went on to then prove this statistically, and I'm not going to show you a huge amount of numbers today. You'll see mainly the visual plots which illustrate the numbers. This is effectively a statistical map of where the strongest activations are coming, and the red areas there show you where the activations are strongest. This is an area of increase, statistically significant increase in oxygenated hemoglobin and a drop in deoxygenated hemoglobin, which we're seeing more in the novice subjects, more on the left side of the cortex. Bear in mind, all these subjects were right-handed, so this is not necessarily a great surprise, but it's the first time, it's a very exciting result for us. It's the first time we're seeing differences, expertise-driven differences in brain behavior. We then went on to prove this in many different ways. Another way here is an inverse correlation analysis between oxygenated and deoxygenated hemoglobin. You can see the area of strongest inverse correlation, i.e. the reddest area, is in the left cortex in the novice subjects. Again, they're the bottom column of data. We then started to think about transient learning and what was happening at a transient level in terms of through the sequence of as you're learning the knots. What we found was that very stable, if you look at the top plot, this is change in oxy and deoxyhemoglobin in the cortex in consultants in the top plot, very stable between the knots and between each other in terms of the group variance. So, not a huge variation amongst the surgeons in the way in which they're using their cortex, and very stable knot-to-knot transition. If you look at if I come back a second, if you look at the novice data there, you can see between the first and second knot, a big change a big jump forward in the amount of processing. By the second knot, there's a lot more attention and concentration than in the first knot. And what that seemed to do was support subsequent improvement in the novice performance between the second and third knot. So as they transitioned from the second to the third, there seemed to be an objective improvement in the time, the path length, the total number of movements. And bear in mind, this was preceded by a significant change in the processing at brain level. So whilst this isn't a direct correlation analysis, we understood this in the context of the brain data to be quite significant. Just to give you some hint on is naive and novice performance, is the distinction important? Well, I think it is. And actually, I'll show you here that Ochida and colleagues, actually, this is data from a laparoscopic suturing task using near-infrared spectroscopy that came out some years after we started to explore this area. And essentially, what this shows, very interestingly, is in a similar way to the findings we found, was that actually if you've got minimal experience or if you're training, you've got some activation in the prefrontal cortex. If you're an expert, you don't really seem to activate your prefrontal cortex. But look at the distinction between expert and no experience. What you should see there is that those subjects with no experience look very similar to the expert group. So, and this is quite an important result because it means that you can't really tell just from the prefrontal. You need to put this in some kind of context. If you just scan the prefrontal cortex, you would say, well, there's no activation, the guy's an expert. But actually, this data really doesn't support that. And our theory on this, and hopefully we'll prove this as we go forward, or at least give you some evidence for it, that actually with a really complex task like laparoscopic intracorporeal knot tying, it's so complex that with no experience, this is meaningless. You haven't got a cognitive strategy. You can't engage a strategy at this point. You can only engage a strategy as you get more experience. And that's when you want to see your trainees. You want to see prefrontal activation at that point, and you want to see it perhaps wane as it gets ingrained. So you've got to take all these things in context. This really is a useful slide because I think it illustrates the danger in just looking at brain function in isolation. But to give you another angle on this, what about success and failure? Well, we didn't look at that in our first knot tying study. We just looked at objective performance as ICSAD would tell us, time, movements, and so on. We redid this with a lot less training in the novice group, and we actually defined success and failure. Those that were able to perform the surgical task and those that simply just could not get it. And what this will show you, I hope, is that for the successful tasks, there was a positive change in the oxygenation in the prefrontal cortex, by and large. With the unsuccessful tasks, we were getting what seems to be a deactivation response, a drop in the oxygenated hemoglobin for tasks that were unsuccessful. But certainly there wasn't the same engagement of the cortex if you failed. than if you were successful at a novice stage in performance. So I think that gives it a slightly different angle. Just to put this into a broader context for you, essentially this data is high dimensional data. We have multiple hemoglobin species, multiple channels, huge number of subjects for NIRS data, over 80, now over 100 subjects. And we wanted to be able to think of a way to see this, for me to show it to you in one plot. Have one way of showing you the whole data set and to reduce the dimensionality on it. Now, the reason why that's important is we do that as surgeons, we do that as humans. We reduce the dimensionality of things in the real world so we can make sense of them, so we can understand them. And the brain is a non-linear organ. So it makes sense to use a non-linear dimensionality reduction technique. Now, we've not included a tremendous amount of maths here, but I'll try to illustrate how this works very briefly. If you imagine a sphere, points taken, a linear point across that sphere does not reflect the underlying topology of that sphere. It's better to take points along the sphere, along the outer edge of the sphere. That makes more sense. And the brain is a similar using the non-linear hypothesis, it's a similar thing. It makes sense to use a non-linear reduction technique to understand this. And to show you how it may work in practice without showing you the brain data first, imagine a scenario of lots of photos of a face in different lighting conditions and up-down poses. It would be very difficult to organize that data automatically. But this technique of isomap, this non-linear reduction technique, does that for you. And what you can see here is that it's organized the data in such a way that up-down pose goes from down to up and the lighting conditions go from left to right. Now, to show you that with respect to our data, we can illustrate this for you and show you the embedding. And essentially what you're looking at now is the entire task data for every single subject, for every single channel. And what it's doing is it's putting the data points in such a way that it's organizing with respect to the underlying activation signals. So you see where the consultant group, the blue group, pop to, the resident group or the registrar group, the green group, and the novice group, who are the red group, the dispersion of those data points. Now, if you really want to understand where is the activation, you take points, as I'm doing now, across the data and up and down, and in a very similar way to the lighting conditions in the head. And what you should see is the data points A and D, which are at the top, the far left and the top apex of the plot, are those signals that look most like activation. In other words, it's the area where the oxygenation rises, the oxyhemoglobin rises, and the deoxyhemoglobin drops. The area at the center of the plot, there's minimal change in both of those species. So this is a way of me showing you in one plot the entire data set for nearly 100 or so subjects, trying to give you some evidence that novice data, novice brain data, is very different to that of expert brain data. What we went on to do then was to train a second cohort of novices, get them to practice and re-evaluate their brain. And what I'm going to show you now in this plot, now that you understand this, I mean, firstly, their performance was significantly better the second time. I mean, that's not so striking, and you would expect that, you would anticipate that from everything you already know. What's really interesting here is what's happening in the brain. So the pink crosses represent the first time point, and you'll see they transition across learning to the green data points, which is their brain data after training, after learning. And what you should see if I put both back together now is that the group have evolved. The brain behavior has moved to an area of the embedding, an area of this plot where the expert group lie. And we can now prove that mathematically by now, if you imagine trying to warp the data points of experts onto novices and residents onto novices. You try and move those data points. You have to work to do that. And this Earth movers distance metric is a measure of that work. It's a measure of how hard do I have to work to morph the data, the brain data of novices onto consultants, novices to registrars, and so on. And hopefully from this left plot you should see that you have to work not tremendously hard to warp the data points of consultants to registrars, but novice to registrars, novice to consultants, you have to work very hard. Another way of showing you numerically that the
registrars are residents.
And registrars are residents, apologies, and consultants will be attendings. So you can see how much harder you have to work novices to attendings, novices to residents, as you would attendings to residents, right? What's even more interesting is if you take that second cohort and do the same thing and compare it to what happened with the first cohort. The first cohort, remember, had very limited training. After training of the second cohort, this is the bright blue on the right plot now, you see you have to work less hard with that second novice group to morph their data points to the attendings. And the same, the novice data points to the residents, the bright green plot, than you did with the previous cohort who were trained to a very limited extent. So there's again another way of showing that something's happened in that second cohort that's improved their brain behaviours. The brain behaviour has evolved. There's been some degree of plasticity in their brain behaviour. And we've gone on to prove this mathematically using random effect analysis. This is just showing you that session before and after learning is an independent predictor of the change in the oxygenation in the brain, the oxyhemoglobin response. Just to give you a couple more slides before we...
Okay. Okay,
yes,
why don't you run through those slides? Okay.
Yeah, I was going to give you one further, two more slides looking at laparoscopy before we take a few questions on the learning side. And essentially, just to show you that we are now bringing this into the laparoscopic arena. We're essentially starting to look at laparoscopic suturing in much the same way that Ochida did. If I move this video forward. Except what we're trying to do is we're trying to understand which parts of the laparoscopic suturing are the most challenging for the trainees. So we're trying to essentially deconstruct the knot tying task down into insertion, double throw, single throw, and so on. And this is very preliminary work. We're essentially looking at laparoscopic suturing, essentially putting 3 knots in. And what we're starting to see, perhaps against the hypothesis or contrary to the hypothesis we would have generated, we would have thought that the double throw knot, which according to, let's say, NASA task load indexes, is more cognitively burdensome, if you will, we would have expected to see more activation at that point, but actually we're not seeing that. So that's a quite interesting finding, but this is very preliminary work. I don't know if you would like to take any questions at that point, Dr. Park. Or...
Sure. Fascinating material and very, very rich for those of us who are seeing this for the first time. We're going to go in a sec to Mount Sinai, but before that, I want to go to our friends at IRCAD in Strasbourg. And I know that your group has been engaged in doing a lot of interesting work in learning and different kinds of visualization. And I just, I guess my question is, most of us are working at a much more rudimentary level when we're looking at really cognitive workload, and so there's a small but growing literature on OR disruption, distraction in the OR. Again, this seems to be somewhat Neanderthal compared to what we've just heard from Daniel. Nevertheless, wanted to know if you have any comment, Bernard, Didier, any comment on some of the training research that is going on there and the visualization that you're doing along with that, surgical visualization work?
Yeah, good morning, Adrian, nice to see you. It was a very interesting talk, and we're looking at the learning curve in the surgery, and the final slide was on laparoscopic surgery. And you know that we are studying a very important program on image-guided surgery, and when we're talking about image, we're looking at image. And my question is, do they have measured the impact of the image that the surgeon is receiving when he's doing minimal access surgery, flexible endoscopy or laparoscopic surgery or whatever? And we know by experience as experts that the quality of the image that we are receiving from a screen or from whatever is extremely important in terms of fatigue and maybe learning curve. I don't know. And my question is regarding that. Do you have looked at the impact of the image on the learning process or the fatigue of the surgeon or whatever?
Daniel, let me hand that to you. Great question.
Yeah, I mean, to answer that question, with respect to fatigue, I'm about to present you some data with respect to fatigue, but not in the context that you described, so not necessarily looking at the visualization as such. But I will try to show you some data that looks at efficiency in the brain with respect to two different ways of performing a task. And I think what you're referring to has parallels there. We certainly now can take two sorts of visualization, monitor the cortical response, and start interrogating not just activation, but the efficiency of the networks, the efficiency of the ways areas are communicating with one another, to get closer to metrics like economy and efficiency and cost, which I think is what you're potentially referring to. Would it be possible to prove that one particular visual display is better than another, for example?
So, I'll just hop in to say this is something that our group looked at a little while ago, and again, with work goes forward to be looking at questions such as this. You can address issues of surgical visualization perhaps in much more sophisticated ways than we've been able to. I want to go to Mount Sinai in New York. We had a question from Mount Sinai.
Yes, it's Barry Salke. Morning or afternoon, wherever you are. I don't pretend to tell you that I understand exactly what he was talking about. That's for sure. We're all looking around the room here and don't understand exactly the neurophysiology behind the presentation. However, just from an experience point of view, having been doing this for a long time and teaching for a long period of time, what's interesting to me is that you're using laparoscopic suturing as a model here, and it was pretty obvious. Let me put it another way. I mean, it's sort of like the Supreme Court decision on pornography. You know, it's hard to define it, but when you see it, you know it. And it's very similar to laparoscopic suturing and advancement of skills and advancement of the ability to do more complex laparoscopic surgery. For me, it was very, very obvious that laparoscopic suturing was the key. It was the way of determining someone's ability to advance to more complicated surgery. And that started back in when we obviously were just doing gallbladders back in 89, 90, 91, in that era. The ability to advance to more complex surgery was key to the ability to suture and knot tie. In fact, a lot of the things that we were using in terms of credentialing had to do with laparoscopic suturing. You had to demonstrate laparoscopic suturing before you could advance to the more complex things. So, I mean, if the data that he's showing now is shown to be true, shouldn't we be looking at testing? Maybe not the fellowship applicants today. It's just key on our mind today because we have fellowship applicants today that we're interviewing, and they're actually watching this. But shouldn't we be using this as a way to test all surgeries, all residents? I mean, the key here is we know that technically, if you're really, really good and you do things slickly, then your incidence of complications tend to be much less than someone who's sort of rips, tears, and shreds through the tissues. Can we use this as a training, as a way to decide who's going to be our next residents, who's going to be our next fellows? Is that too much information for everybody?
No, that's very. That's a great question, Barry, and it kind of harkens back to how Daniel actually laid out the context at the introduction, raising questions. Are there different ways? Can we be using this technology, these techniques, to speak to credentialing, accreditation, or selection of trainees? Daniel, in handing over this for you to respond, we have about 5 minutes, and I know you have a tremendous amount of data. So if I can just ask you to get to the salient points, respond to, if you would, to Dr. Salke's question, and then we'll have about 5 minutes to pull this together. Obviously, fascinating and very rich data you're presenting.
Yeah, I think just to answer that point, I think that yeah, we can't discount neuroplasticity as a way of understanding performance for sure. I mean, we've certainly seeing that come through in the data, and particularly with respect to, as we've put, laparoscopic suturing. We are, although I'm not able to present that data today, we are seeing that there are trainees that are needing to come back for remedial performance just to get through the study in order to be able to get through to the next round of the study. And we're analysing the brain behaviour of those subjects that perhaps need more time, more training, if nothing else, just to help identify those people earlier. Not necessarily to select them away from surgery, but to at least identify those that would benefit from more cognitive training, let's say. So, are you happy for me to move on to the next slide?
Yeah.
So, to pick up again the point that was raised before about fatigue and try to show you some data on that, I became very interested in this area while I was doing my PhD. I think the reason for it was that it became clear to me that in the UK at least, and I'm fairly certain as well in the US, that the hours of work were changing for residents. We were moving, or because of the European Working Time Directive, we were essentially moving to a more shift-based system and trying to move away from the protracted long hours of on-call and so on. But the shift system gave us different issues. We know that the surgeons were still sleep deprived despite this change in working patterns, and that sleep deprivation has a major consequence on your cognitive performance, greater lapses in attention. We know from data that's been done, more diagnostic errors, and more errors in prescribing and so on. With respect to technical skills, there's a lot of data looking at technical skills, fatigue-induced performance decline, if you like, with respect to technical skills. We performed a study in 2008, essentially looking at this effect across a week of nights. Our hypothesis was that by the time you got to night 7, you would probably see an increase in the number of errors in your performance and slower performance and so on. Actually, we found, to our surprise, that actually night 1 is the dangerous night. There may be lots of different reasons for that, which we can perhaps discuss in the breakout session. But essentially, when you come on shift, you are potentially dangerous. And this is despite the fact that actually you don't realise that you're tired. The Epworth Sleepiness Score, which is a way of monitoring how tired you feel, you're not perceiving it very well that you're tired, or that your skills are perhaps not as good as they should be. So what I wanted to do is go and study this night 1 effect, what's going on in this first night, and get a better sense of what's actually happening through the night shift at night. What I was noticing from the literature was that we were doing this great work, but we were doing work where we were studying the trainee at a point where the trainee would have gone home. I mean, we'd have done 24 hours on call, and then we bring them in for an analysis. The trainee the resident would have essentially exited the hospital at that point, and it's not really a risk to anyone at that point. I believe what you need to do is capture the data at the time things are happening. You need to see what's happening in the brain through the night shift to understand what's happening at night. And there's lots of reasons why the work hasn't really been done in that. It's very difficult work to A, do, and B, you don't get a lot of friends amongst your resident colleagues by getting them to do additional night shifts to survey what's happening at night. But essentially we managed to do this study looking at cognitive skills and technical skills, where essentially trainees came in and were evaluated at 2-hourly intervals from 10 p.m. the night before through to 8 o'clock the next morning. And they did the open surgical knot tying in much the same way that you saw before, except they also did an arithmetic task using the Nintendo brain training device, which conveniently gives you a score at the end. So that's essentially the outline of the study. To show you what we found, well, essentially, perhaps unsurprisingly, through the night shift, residents became fatigued. And we've shown that actually they reached abnormal levels of fatigue really by 4 in the morning. There were significant increases in fatigue, however, at the early stages from 10 till midnight and from midnight till 2 in the morning. What we found with their technical performance and their cognitive performance was that there was a warm-up effect, essentially, with the knot tying performance. They got better initially, between 10 and midnight, and then worse again between midnight and 2, and then stabilised thereafter. So there wasn't really huge shifts in their technical performance, nor in their cognitive performance. In fact, their cognitive performance on a basic arithmetic task remained consistent throughout the night shift. What was very interesting was the brain data. And what we found was that the brain data for the cognitive task was vastly different from the not time task. Firstly, you're seeing a lot more activation on the cognitive task at the prefrontal level than you are with the not time task. This is more evidence to show you that in subjects where not time is ingrained, they don't really need a tremendous amount of activation. They need a lot more activation for their cognitive skills. What's also interesting, and you'll see it in the next slide more clearly, is that between the hours of 4 and 6 in the morning, there was essentially a sharpening of the response, a greater increase in the response, which is manifest more clearly in this plot, which shows you the oxygenated hemoglobin change and the total hemoglobin change through the night shift, A to F being from 10 o'clock in the evening the day before till 8 o'clock the morning the next morning. And I hope what you can see from this again is the two clear findings. There's not a tremendous amount of cortical oxygenation change, or i.e. activation in the brain for the technical task. There's a lot more for the arithmetic task. And for this cognitive task, at around the time where maximal fatigue was observed, there seems to be this need for let's call it a boost, or what we called it, this kind of cognitive compensation that's going on in the trainees around that time to maintain their performance. But again, it's another illustration that you would not see this had you just looked at their performance. If you looked at their cognitive and their technical performance, you would have concluded that these residents, these surgeons, are performing exactly the same as they were at 10 o'clock the night before. That's simply not true. Their brain behavior is completely different. Now, the reason why this is, to us, why we feel this is very significant, is that we know the brain has limited resource capacity. If you're using this much more of your cortex than is required to achieve the same performance, you're probably not thinking about other aspects of patient safety, decision making, who knows. So I hope this slide's clear in the sense that the key findings are those differences between the amount of brain activation that we saw on the technical and cognitive task and this longitudinal effect that's associated with fatigue. The more fatigued you are, the more it seems you need to use your prefrontal cortex for basic cognitive functioning, and possibly alarmingly, you may not have other capacity to be thinking about other things. So I think we'll pause at that point if there's any other questions on the fatigue.
I think there's a lot of cortical deoxygenation right now, just on the basis of this marvelous information you're presenting, which it's fascinating. So many questions. I do wonder if math, if there had been other kind of problems other than math. I'm assuming that you would expect the same level of recruitment and activation, even if it wasn't a math problem. I think, Daniel, unfortunately, we're going to have to tie things up at this point. At this end, many of the centers have to get off to the operating room now. You've done more than whet our appetite here. You have introduced really a new way to think about not just training, but how we perform as surgeons cognitively and technically, and ways that we can think about harnessing this technology. I know it's still in evolution, but thank you so very much for introducing us to these marvelous concepts. So Professor Darzi, appreciate your involvement, Daniel, and the whole rest of the team. It's just been a delight. We've got lots to chew on. As I say, I think there's a fair bit of cortical deoxygenation across the continent right now. So thank you very much. I do want to remind the audience that our next program is October the 5th. Cleveland Clinic Weston will be presenting, moderated by Dr. Wexner, and the presenter will be Dr. Megan Castidio on single-port colorectal surgery. So I thank the audience, and once again, Professor Darzi, Mr. Leff, and the team at Imperial College for a very stimulating presentation. Thank you very much.